Now I invite Kosal Ram sir, the Neurosciences Forum, which we are conducting every month. And this month, we are having the International Epilepsy Day. So we thought of having an epilepsy topic from one of our stalwarts of epilepsy, who is treating lot of patients in the region of Coimbatore, in and around Coimbatore, all around. And another speaker will be Dr. Bhagat Singh, who is doing the neuroendoscopy, and he is doing routinely, and he is one of the active member of the Endoscopic Society of India. So today we are having a nice uh, thing. We have released one uh, small video for the epilepsy, for the International Epilepsy Day. I wanted to run it out here and show it to you. International Epilepsy Day is observed on the second Monday in every February. This was a short video that we released from Coimbatore, from our College of General Practitioners. This was the video which we released from IMA Coimbatore. And today we will straight away go for the program. Now we will have the first speaker of the day, Dr. Rajesh Shankar Iyer. Naveen, Dr. Rajesh Shankar Iyer is a consultant neurologist and epileptologist and critical care neurologist in KMCH, Coimbatore. And he has got a lot of degrees, MD, DM, and MRCP neurology from UK, and FRCP Glasgow and London, and fellow of the European Board of Neurology, fellow of the American College of Physicians, fellow in neurocritical care, European diploma in ischemic stroke intervention. Uh, he has got more than 50 publications, and the area of specialization is epilepsy, critical care neurology, stroke, autoimmune disorders. Achievements and awards: established the first comprehensive epilepsy care center in the West Tamil Nadu and conducted more than 170 epilepsy surgeries so far. Received the A.B. Baker and Teacher Recognition Award from the American Academy of Neurology in 2024, and the Merida Spirit of Neurology Award from the American Brain Foundation in 2025 for his contribution to epilepsy. Chief editor of monograph of the Indian College of Physicians, API, titled Epilepsy 2017 and Autoimmune Neurology in 2018. Reviewers of journals including BMJ case reports, Lancet Southeast Asia, Epilepsy Research, Seizures, Pediatric Neurology, Journal of Child Neurology and Epilepsy, etc. I welcome Dr. Rajesh Shankar Iyer to give his lecture.
Thank you, Rajesh Babu sir. Am I audible?
Yes, sir.
Yes, sir, you are very much audible, sir. Thank you so much, sir.
Thank you, sir. And I thank the organizers for giving me the opportunity, IMA Coimbatore especially. And as Rajesh Babu sir has mentioned, it may be the appropriate opportunity to talk about epilepsy, especially epilepsy in women, during the time of International Epilepsy Day. So I'll share the slides. So is it visible?
Yes, sir.
Okay, so today's topic, I'm audible and visible now. Once again, I'm confirming.
Yes, sir.
Sir, you can put the slideshow, sir.
Okay, slideshow started, sir. Is it visible?
No, slideshow has to come.
No, that
First
big
slide is
slideshow, it is not. We tried before, it's not working.
Okay, it's all right. You continue with this.
Okay.
No problem. Thank you.
So today's topic is women with epilepsy. So there are many aspects when we deal with women with epilepsy. So let me take each one separately. So first and foremost is the catamenial epilepsy. So what are the patterns of catamenial epilepsy? Catamenial epilepsy is the occurrence of seizures in and around the periods time. So it is there are three different patterns which are identified. It is called the catamenial pattern 1, 2, and 3. That is if the menstrual day, the first menstrual day is considered as day 1. So from the -3, that is 2 days before, to +3 period, which we call as a perimenstrual period, people can have clustering of seizures at that time. So what is the cause? This is the decreased progesterone at that point of time. So we all know that estrogen is actually a epileptogenic hormone, or it can promote seizures, and progesterone is anti-seizure hormone. So perimenstrually, there is a decrease in progesterone, which may be contributing towards the first pattern called the C1 catamenial pattern. And C2 is the peri-ovulatory pattern. So as you know, from the ovulatory cycle, from the time of ovulation till the periods of the 14 days is fixed. But the ovulation can variably occur from, say, 14 to 20 days. So from the 10th day to the -13, that means the day before the period is the -1, and then you go behind -2, like that. So -13th period till that time will be the peri-ovulatory period. So that is the time when the hormonal change will be, as you all know, there will be LH surge, there will be increased estrogen. So increased estrogen is the cause at that point of time. Then some patients can have the C3 pattern, which is from the day 10 to day 3. That is supposed to be due to it's called inadequate luteal phase, and it's because of the increased estrogen progesterone ratio. That is more of estrogen and less of progesterone. That particular thing will cause the seizures. Now the important thing is that the C2 and C3 is quite variable, and we will not be able to exactly fix the pattern of seizures, whether it's really happening within the ovulatory time, or suppose somebody is having a seizure frequency of 6 or 7 seizures per month. It's very difficult for us to clearly fix whether it is the C2 pattern, C3 pattern, but the C1 is very easy for us to understand, happening in and around the menstruation time, -3 to +3. And that is only more important because that is the one thing which might be amenable to treatment also. The C2 and C3 may not be helping us much in terms of treatment. Now, the people have found that if there is, from the routine seizure frequency of the patient, if there is more 2 or 3-fold increase in the seizures between the -3 to +3, then that is the patient where you can give some treatment which is more than the anti-seizure medicine. As you see, the C1 is decreased progesterone. So in those patients who are having great number of seizures from -3 to +3 of the periods, this cyclic progesterone treatment can be attempted. So that is, the progesterone lozenges are available at 200 milligram. That is the day 1 is supposed to be the first day of menses. So 1 lozenge TID will be from day 14 to 25. Half lozenge TID is from day 26 to 27, and 1/4 lozenge TID from day 28, and stop on day 29. So this particular treatment we can adopt in those patients who are having very high seizure frequency perimenstrually, and there the progesterone supplementation like this will help them reduce the number of seizures. So that is one aspect of catamenial epilepsy. Then the other treatments in catamenial epilepsy, medroxyprogesterone administration to produce amenorrhea can have around 40% seizure reduction, especially in those patients who are having increased seizures in and around that menstruation period. The other drugs which are tried are acetazolamide and clobazam during the period of menses with very limited success. So this is one thing which we can see when the patient complains about real increase in the number of seizures in and around periods time. We can consider the treatment with the progesterone or medroxyprogesterone. That is one point which I want to stress, which is more than our routine usage of anti-seizure medications. Then the reproductive and sexual function, what happens in people with the women with epilepsy? Generally, they are normally fertile without much problems, but some can have reduced fertility. So there are some patients who do not have children, fertility is less. That is because of the factor of epilepsy. What happens? What does epilepsy do onto the reproductive hormones? So what happens is that the GnRH, which is produced in the hypothalamus, can be vulnerable to repeated seizure or injury caused by repeated seizures. So when the GnRH is not produced, the release of FSH and LH. As you all know, the first part of the ovulation, pre-ovulatory period, the FSH is very important, and then subsequently on day 14, the LH surge, which is very important for the menstrual cycle. So when this does not happen because of the seizure injuring the hypothalamus, thereby decreasing the production of the gonadotropin releasing hormone, this may lead to a situation of hypogonadotrophic hypogonadism. So this can result in decreased fertility. Then the other thing which we all are very much worried about is what is the effect of anti-seizure medications on reproductive hormones. So we know that some of the anti-seizure medications are enzyme inducing. So currently the usage is not AEDs, though I have mentioned interchangeably, it is ASMs. They are better known as anti-seizure medications and not anti-epilepsy drugs, because the epileptic and epilepsy, these usages, International Epilepsy Association advises us to reduce the usage of epileptic, to calling somebody as epileptic and epilepsy. So we call it as anti-seizure medications. So enzyme-inducing anti-seizure medications can alter the hepatic metabolism, and what they can do is decrease the amount of reproductive hormones in the patient. And these drugs can also induce the production of the sex hormone binding globulin. So thereby, once they are bound by this globulin, they reduce the concentrations of the free hormones in the serum. Then these drugs can also cause low total testosterone concentrations and increase in the decrease free androgen in men if they are taking especially the enzyme-inducing carbamazepine or oxcarbazepine. And because of the low total testosterone and free androgen levels, which can result in decreased sex drive. So loss of libido can happen in men. So these are the important things which one should also inquire in detail about when you find out the reasons for infertility in these patients who are taking medications for a long period of time. So some anti-seizure drugs can also alter the hormonal production. For example, sodium valproate has been reported to induce androgen synthesis in the ovaries. So this valproate can thus be associated with the increased testosterone concentrations, anovulation, and polycystic ovary syndrome. So that is, valproate is especially known for this. So what is the effect of the reproductive hormones on anti-epileptic drugs? The levels of anti-seizure medications may fluctuate during the menstrual cycle due to the hormonal effects. And what happens is during the luteal phase, there is high levels of circulating estrogen. This could induce the hepatic isoenzymes, which are used for the antiseizure metabolism, and therefore they can lower the level of the circulating antiseizure medications premenstrually. So this can happen because of the effect of the estrogen and progesterone. That is, especially the high levels of estrogen can decrease the levels of antiseizure medication premenstrually. So that's why I said estrogen is predominantly seizurogenic and progesterone is seizure protecting hormone. So third factor which we would like to consider is the contraception. When women with epilepsy, when you are considering the contraception, we should think about the groups of drugs which are strong inducers of hepatic metabolism, weak inducers, and non-inducers. So when you use these strong inducers, then it is likely that the contraception can fail. So anti-seizure medications, the non-inducers are the safest, of which I would like to name some of them, like our routine lacosamide, sonazamide, levetiracetam, valproate. Actually, valproate is enzyme inhibitor. So these are the drugs which can be okay when you're thinking about contraception generally. But the drugs to be avoided in people who you prescribe, especially this is with regard to the oral contraceptive pills, you have to avoid phenytoin, phenobarbital, carbamazepine, oxcarbazepine, primidone, perampanel, which are very strong inducers of the hepatic enzyme. They'll make the contraceptive agent inactive or ineffective. So these anti-seizure medications with having a potential for enzyme induction may accelerate the hepatic metabolism of the oral contraceptive pills and other hormonal contraceptives. So as I showed in the list, the non-enzyme inducing ASMs do not influence the hormonal contraceptive metabolism, so they can be used without the risk of contraceptive failure. So now that most of the people are using levetiracetam, that will be a good option in these situations. So it will not cause the contraceptive failure, and also lacosamide is also safe in these situations, and valproate, the commonly used drug, is also okay. Clonazepam is also okay. Sonazamide is also okay, non-inducers. So the oral contraceptive pills can increase the elimination of anti-seizure medications that are metabolized by glucuronidation. So this has been best studied for lamotrigine. So what happens is that the metabolism of lamotrigine will be accelerated by 50% by the oral contraceptive pills. So we saw what the anti-seizure can do to the contraceptive medications. They can make them ineffective. Similarly, what the oral contraceptive pill can do to the anti-seizure drugs, that is, the lamotrigine levels will be reduced because the metabolism will be accelerated by the oral contraceptive pills, and the clearance of valproic acid is also increased with the combined oral contraceptive pills. Valproate clearance is also increased. Though valproate can be used because it's not an enzyme inducer, the valproate can be cleared off very rapidly with the use of contraceptive pills. So what is the ideal choice of contraception? If you want to talk about, so we've spoken so much theory. So in a given situation, the things to remember is that if you are giving combined oral contraceptive pill, levetiracetam, lacosamide may be very safe. To put the very commonly used drugs, these two drugs are safe. Now, if you want to choose the contraception, go for IUD. So in a single word, these are the two important things to remember. So in a IUD is the best choice for contraception, especially the levonorgestrel IUD. It prevents pregnancy by local hormonal mediated changes only. So this is unlikely to be affected by the enzyme inducing anti-seizure drugs. So points which I want to highlight is in patients whom you are giving the oral contraceptive pills, usage of levetiracetam and lacosamide can be safely used. Though other drugs are also there, these two drugs you can keep in mind. And when you counsel the patient for contraception, go for IUD. The levonorgestrel IUD is the best because it works on the local arena and The systemically acting anti-seizure drugs has nothing to do with that. So the next important thing, so we looked into the catamenial aspect, the seizures happening with the periods, where progesterone can be a treatment. Then we looked into how the fertility gets affected in women. In some women, not all, very few of them can have fertility issues. Then we looked into the contraception, what we should do, which drug we should choose when you are giving combined oral contraceptive pills, and what actually is the ideal way of contraception in women with epilepsy, which is IUD. Now, having looked into all those aspects in women, let us look into the pregnancy, which is one aspect which is very frequently discussed by everybody. And this is one area which creates a lot of confusion among the general practitioners and so much worry among the patients about what happens if they take the anti-seizure medication, how much it's going to affect the fetus and the children, how they are going to affect it. The most important thing which I would like to tell at the beginning itself is that yes, we have risks with these medications, but the point to remember is majority of the patients do well with the anti-seizure medications, number one. Number two is having maternal seizures is much more problematic than thinking about this teratogenicity. So if you weigh these two things, you should be acting more for preventing the maternal seizures. So though the fact that these drugs can cause problems, the most important thing is that many of the pregnancies will go unaffected, and preventing maternal seizures is much more important. So many situations will come where suddenly the patients, so the most important thing in pregnancy management is that the preconception counseling. For that, how many people are going to come to us telling that we are taking anti-seizure medications, we would like to have family, and what's your advice? And very few people come. So they get pregnant, and mostly they will be coming after pregnancy only, or after the UPT is positive, they meet the doctor immediately. We are pregnant and whatever. So this is that is the time when we are really in a fix where we are not able to do much with the anti-seizure medication. So the women with epilepsy should be really encouraged to have a pre-conception counseling. Even before marriage, they can be given this counseling that you need a lot of information about how to proceed with it. And before marriage itself, they should meet the doctor for a decision on the anti-seizure medications and what all they should do, what all they should not do. These aspects, if they come before marriage itself, that will be very good. So we have seen many situations where many of the patients are stable with anti-seizure medications, so they don't meet the doctor, and then they come after marriage with a positive pregnancy test. Now, having mentioned some of the important aspects there, let us go into the individual details. Like, what is the risk of the congenital malformations with the anti-seizure medications? Before that, we should know what are the major malformations and the minor malformations. So major malformations are life-threatening, that will have a major impact on the person, like the neural tube defects and other things, and they may require surgical treatment. So they are the major malformations. So if you look at the general population, the major malformation is around, say, let us say 3%. Whereas among the anti-seizure drug users, it is say around 6, 7, 8. So various studies are shown. So on as a rule of thumb, you can say that there is a twofold rise or twofold higher chance that they get the major malformations. But remember, this twofold only means from 1.5 to 3 or 3 to 6. So I think basically we should not scare the women. So the problem is, I used to tell my patients, so supposing there are 5,000 women who are delivering a child in a given day, say for example 3 children are going to have some malformations, and on the same day 5,000 women who are taking anti-seizure medications are delivering the child. So their 6 children are having major malformations. So in 5,000 women who are not taking anti-seizure medications, say some 3 or 4, let us say 10 children. Here 20 children are having malformations. So if you take 5,000, 4,880 are okay. So in the other one, 4,890 are okay. So it is, if you say it is twofold or 3 times the chance, then people get scared. But the actual number is only 5%, 6%. So I think we should tell them that don't worry, the chances are more, but we have various options to, we see many patients getting scared. They run from pillar to post. I am taking valproate. My doctor has told that it is this, please abort the child. It's nothing like that. I mean, one need not be so scared about the fact that the patient has been on a particular drug, and we should actually tell the patient that, of course, there are some risks, but we have ways to overcome that. And many of the patients, majority of the patients, 90% or more are going to have delivery, and the children are going to be okay. So what all we should do to make sure that the child is okay, we will do. So I see many of the women are really panicking once they have the diagnosis of pregnancy, and once they meet the practitioner, they get panicked also, because they misunderstand what is being told to them. When we tell them that there's a twofold rise, they get really panicked. So what are the minor anomalies? Minor anomalies are anomalies which do not constitute a health threat. So that can happen around 2.5 times more than the general population. So to easily remember, both the major and minor malformations are 2 to 3 times more than what is seen in the general population. So some of the minor anomalies are the micropnea, syndactyly, polydactyly, etc. So various registries are there. Our Indian registry is there in Sri Chitra, where the late Sanjeev Thomas sir was the pioneer in establishing the Kerala registry. So that also, most of them are showing the prevalence of congenital malformations for the monotherapy. What we are showing here is that if the patient is on a single drug. So if the patient is on multiple drugs, the scenario totally changes, and you'll have much more increased chance of getting malformations. So let us look at the monotherapy, and the chance of risk is, look at carbamazepine. It varies from 3 to 5%. Look at lamotrigine. It varies from 2 to 3%. Levetiracetam is around the same, around 1 to 2 or 1 to 3%. So most of them are around 2 to 3%, whereas valproate goes a little bit higher to 7 to 10%. So valproate is on a higher side. Phenytoin is around 3 to 6% in the various studies. So generally, as a rule of the thumb, we can say that it's around 3 to 6% prevalence of congenital malformations, all taken together, major and minor, if the patient is on a single drug. So even with a single drug, say 3 out of 100 is going to have some abnormalities. So again, this is from the another, I'm doing the details about the North American pregnancy registry. As you can see, the yellow highlighted one, the major congenital malformations alone. That is again, as you see, 1%, 2% like that. So the major malformations is slightly on the lesser side, because you can see that for example, let me take valproate is 9.3%. When you see the major congenital malformations, that is the highest one is valproate, and phenobarbital comes behind with the 5.5, and topiramate and phenytoin in around the 3 to 4%. So the least is going to be with gabapentin we don't use as anti-seizure. The least is going to be with the lamotrigine. So if the unexposed, that is people who are not taking, is 1.1, then it is 2 in lamotrigine. So lamotrigine is one of the safest, and slightly more, 2.4 with levetiracetam. So again, it's only 2.2 as you can see in oxcarbazepine. So which are the drugs which are coming within the 3% scenario is lamotrigine, levetiracetam, and oxcarbazepine. So if you see, carbamazepine is on the higher side, whereas oxcarbazepine is on the lower side. So these are the 3 drugs: lamotrigine, levetiracetam, and oxcarbazepine. You can see oxcarbazepine is even better when compared to levetiracetam in terms of the major congenital malformations. Okay, so this is a relative risk when compared to the lamotrigine. What happens, because if you take lamotrigine as the benchmark, we can see that the relative risk is around 1.5 times with carbamazepine compared to lamotrigine. You can see that it is around 5 times in valproate and 2.2 times in topiramate, etc., etc. So summarizing this particular aspect, I would say that the least affected or the least damaging drugs are the lamotrigine, levetiracetam, and oxcarbazepine. And the drug with maximum problems, which everybody is aware of, is valproate. Following that is phenobarbital and topiramate. Topiramate has many minor malformations. So the valproate, just for a recall of the many of the malformations, valproate produces spina bifida, phenobarbital produces cardiac defects. So very problematic for the child. And topiramate produces the facial clefts and hypospadias, which I believe can be surgically corrected in many situations. So far our understanding has been the major and minor malformations. So we all knew that it is in the first trimester when the organogenesis happens. So there is another concept which I would like to stress here for everybody's information, is that it is not only the first trimester. Throughout the pregnancy period, there are impacts of the anti-seizure medications on the women, on the fetus. So we are actually like telling a lot of problems. At the same time, we should say we are telling that the women should be positively counseled. Yes, there are risks, but still, again, we should only counsel them positively. The fact which I'm going to tell you now is that the cognitive and behavioral problems have been recently identified as a problem in some of the medications, where the impact is not during the organogenesis of the first trimester. This particular impact is because of the continuous exposure to the drug during the brain development, which happens in the second and third trimester also. So it is not that the risks are limited to the first trimester. It is problems are there, especially the cognitive and behavioral teratogenicity. So fetal valproate exposure has reduced cognitive abilities across a range of domains, low IQ, and these are, in many studies, they have been shown to persist until the age of 6. So this is also another aspect. Unfortunately, the problems are not restricted to congenital anatomic malformations. It is also, there is an impact on the cognitive aspect, which you should all think of. That is why we should always strive for a monotherapy, but it is not practical in many situations. But as much as possible, if the patient comes for preconception scenario counseling, we can always try and see what can be done in terms of decreasing the anti-seizure medications. So the low verbal intelligence, it can be there as part of phenobarbital and phenytoin toxicity. Now again, the new drugs of lamotrigine, levetiracetam are found to be not causing much cognitive damage compared with other anti-seizure medications. So when you look into the various data, we know why there is a tremendous spike in the use of levetiracetam, lamotrigine, etc. is all because of the lack of tetragenicity, as well as even with regard to cognition, they seem to be much safer compared to other anti-seizure medications. So this is one information in one particular study, which they found that compared to the control group, they found there's a significant occurrence of ASD, autism, in the women who are exposed to valproate. So this is around tenfold more than what is seen in the general population. So what is seen in the valproate group, and we are waiting for many studies to whether this particular information is going to be replicated or not, but there seems to be a definite association of valproate use and the occurrence of autistic spectrum disorder. So on one side, we can say that our worries about anti-seizure medications are correct because we are talking about so much problems. We have gone beyond the first trimester. We are telling now there is a cognitive impact on children. We are telling now there is a possibility of autistic spectrum disorder happening in women who are exposed to valproate. So what is a birth outcome? And again, there is more chance of preterm delivery, the children being SG small for gestational age. This especially is more with valproate and carbamazepine. And the 1 minute Apgar scores also reduced score occurred more with the phenytoin and valproate. That means if we can avoid these drugs which have been time tested and very good for very good efficacy wise, that is, there is still, I would say, no drug to substitute for carbamazepine, phenytoin, sodium valproate for efficacy. But for the side effect profile, especially when we are talking today about women with epilepsy, if they are out of these drugs, then it is very good. We are probably avoiding most of the problems of which I have been discussing now. Most of the problems are very less with the newer drugs and much more with the conventional drugs. But again, look at this, topiramate or zonisamide is associated with the low birth weights. So it's also the newer drugs are also having impact in various ways. So the small for gestational age was 6.8% for lamotrigine, and around 20% for topiramate and 12% for zonisamide. So don't have the idea that the newer drugs are safe, but compared to the conventional drugs, I think the newer drugs are scoring over them in various situations, and they are better. The women are better off with the newer drugs compared to the older drugs. But again, all these aspects should be decided based on the seizure control of the mother. There cannot be a compromise on the seizure control of the mother and action based only on or only considering the benefit of the fetus. Because if you do that, many complications can arise with repeated seizures of the mother. So first and foremost is, of course, whether we are controlling the seizures of the mother, though we have so much information about all these drugs. So I am telling that monotherapy is the best. When the women will already be having very frequent seizures, and especially those women with drug-refractory, drug-resistant epilepsy, it's not going to be possible for us to do this. So we can only talk about the patient being on monotherapy. In some situations, if we take that effort, we'll be able to do that. But we all know that in many situations, we'll be compromising on the seizure control. So that is the first thing which we should focus. And then we should look into all these things, how much it is possible. That is one point which I'd like to stress here. So coming to the folic acid, it's again a controversial thing, whether it is really helping us. But then as of now, the recommendation is that at least 3 months before conception, you should start folic acid and continue at least in the first trimester to reduce the risk of neural tube defects. And some of the guidelines say 400 micrograms or 400 milligram daily is enough, but some strongly recommend 5 milligram daily from 3 months before conception and continue at least till the first trimester. So basically, I would say here that if you give for every woman with anti-seizure medication 5 milligram daily, I don't think folic acid is causing any toxic effects. So you can give 5 milligram daily from 3 months prior and continue. There is no problem. This is very important if you give the carbamazepine, phenytoin, valproate, those drugs. If the women are on these drugs, we have to give 5 milligram daily. The question of this lesser dose arises only when the patients are on the newer drugs where the risks are less. Then we can consider, in some of the guidelines are suggesting 0.4 milligram. So if you take the total per week, only 2.8 milligram is only we are giving. But if you give 5, it means 35. So it's like 2.8 milligram versus 35 milligram. But so far, there is no information on the folic acid producing any side effects if you give. So I would say that as a rule of the thumb, 5 milligram daily, starting from 3 months prior to 3 months before marriage, because we don't know the conception time. So I would say instead of 3 months before conception, I would say 3 months before marriage, and should be continued through pregnancy, but at least the first trimester. So other thing which you all are aware of is the alterations in the drug metabolism in pregnant women with epilepsy. They can have the first trimester nausea, vomiting, so the drugs may not be reaching the system, and they can have increased volume of distribution. So what happens is that there can be a serum albumin reduction because of the increased volume of fluid in them. So the protein-bound drugs can be reduced in concentrations, especially the phenytoin and valproate. So you can have a reduction in the concentration. The renal blood flow can reduce, it can increase in, will increase in pregnancy. So the concentrations of levetiracetam, sonizamide, these are the two common drugs which we use. The other ones we don't use. They can get reduced because of the renal blood flow. Then what happens is that there is induction of hepatic enzymes. So that can produce reduction of most of the drug concentrations, lamotrigine, valproate, sonizamide, and the oxcarbazepine also. So most of the drugs levels can drop during pregnancy. So what are we going to do for that? So they say the levels can be monitored. Especially this happens after the second trimester, 6 months onwards, when the volume of distribution is going to be increased. So the level monitoring is not really readily available in our setup. So, and many a times the levels may not really correlate with the efficacy also. So in our setup, if possible, you can do, but generally, there are two ways of dealing with it. You can increase the dose from the 6th month onwards till delivery, and then immediately after a week after delivery, you can start decreasing the dose and bring it to the previous level over a 1 month period of time. That is one thing which is possible. The other one is if the not doing anything, only if the patient develops a seizure at that time, you assume or understand that it is because of the dilution which is happening. Many times it's more likely that our patients are missing the tablet than the dilution part. So then you can hike up the dose and then do the same thing. So these are the two options available for us. Though in the Western scenario, many of the practitioners use frequent enzyme, the drug monitoring in these women, but I generally don't do. But I did warn them that there is a possibility that we might have to increase. And many of our women I see going through that stage without getting any seizures. I always tell them that if you miss the drug, then your child will be affected. And that is true also, because the seizures will happen, and the seizures will cause, maternal seizures will cause a lot of effect on the fetus. So because of that, I find very good adherence to drugs in our women, especially during that 9 months period, because once you tell them that you miss the drug, you are actually causing damage to the fetus. Actually, they might be thinking the other way around. If I'm taking the drug, I'm damaging the fetus. But actually, you should tell them that if you miss the drug, you are damaging the fetus. So they will be taking the drug religiously and avoiding seizures. Getting seizures is the most troublesome thing during pregnancy. So we should go all out to avoid seizure syndrome. So the next thing, when we have discussed some aspects of pregnancy, I know it's a vast topic. Maybe there are a lot of issues which we have not covered in pregnancy. Main thing which I would like to say, again, I'm repeating, is that the mother should be free of seizures. We should encourage the women to have a preconception counseling. We should try and bring the drugs to monotherapy. We should try and avoid the conventional or the proven drugs, the conventional age-old drugs, and put them on the newer drugs if possible. But all said and done, the ultimate aim is to have no seizures for the women during the period of pregnancy. Again, I know there are a lot of controversies we possibly will be discussing. Now, the important part is the breastfeeding. Very important. Breastfeeding can be recommended. And there is no scientific evidence to support any risk to the child because of breastfeeding with any of the anti-seizure medications. So you can just ask them to breastfeed all the anti-seizure medication. There's absolutely no problem with any of the medications. Then we should also be aware of the peripartum psychiatric comorbidities. After the delivery, many of them can have anxiety and depression, which are more in women with epilepsy in the peripartum period. It has been found to be more than what is seen routinely in other women who are not on anti-seizure medications. And one more thing is that there is a possibility, as I mentioned earlier, is that because of the effect maybe of the epilepsy as well as the drugs on the hypothalamus, there is a possibility of a premature menopause in many of the women with epilepsy, which is characterized by amenorrhea and ovarian failure. So their menopause might happen a bit early. So you have seen that one more aspect is the bone density. And these women generally after menopause, you have a significant reduction in the bone mass, osteopenia, osteoporosis all setting in. And people who are anti-seizures are having increased risk. So we should be very careful. We should evaluate them, especially after the age of 40. BMD should be done, and calcium supplementation, and as and when required, the treatment of osteopenia, osteoporosis should be undertaken in women with anti-seizure drugs. One important thing is that the vitamin K, which I have not mentioned here, and previously it was mentioned as a regular thing, especially on the 37th and 38th weeks to prevent hemorrhagic disease in newborn. But currently it is not recommended. There's not sufficient data to support the use of vitamin K in women to prevent this particular complication. Many studies have shown that there is no increased risk of bleeding in people who are not on vitamin K. But if the patient is on enzyme-inducing drugs like carbamazepine and phenytoin, phenobarbital, we can give vitamin K in the 37 and 38 weeks. But currently, it is not even discussed in many of the articles because it's not recommended as a routine in women with epilepsy. So we have discussed various aspects of women, as you see, that they can be affected in every point of time with the seizures. Especially we see women at the JME in the second trimester struggling to get married, and they see that they get more seizures with the catamenial epilepsy. With the periods, they get more seizures during pregnancy. A lot of issues in the house because they are throwing seizures. So women go through hell with epilepsy, especially in our setup. They're having a torrid time with epilepsy, and their hormones are not going to. Their hormones are making matter worse for them. So they need all kind of consideration, and we should have a proper management of women with epilepsy at various stages. So what are the important points which I mentioned? I just mentioned them as take homes. The first and foremost thing for everybody is to remember that estrogen is pro-convulsant and progesterone is anti-convulsant. Number one. Number two, the catamenial epilepsy, the one which is having -3 to +3, that's 3 days before periods and the 3 days after periods clustering of seizures. The treatment with progesterone can be advised. Third point is that if you want to give contraception, IUD is the best. If you want to choose a drug which can not interfere with the your combined oral receptive pills is going to be, as I mentioned, the lamotrigine, levetiracetam, lacosamide group. And if IUD is not advised, then the long-acting drugs like intramuscular medroxyprogesterone, it has the side effects of vomiting and all those things, but they can be used because the enzyme induction doesn't have much effect in longer-acting drugs. So the second choice after the IUD is going to be the medroxyprogesterone. That's the point which I want to mention. Pre-conception counseling is the fourth point, and we should be counseled about the various aspects, what is starting folic acid early, and what is the importance of not having seizure, what's the importance of not missing the drug, what's the importance of immediately reporting if you are having a seizure, and the various maternal and fetal outcomes can be discussed with them. And we should not scare them, only discuss with them the various aspects. And why should they undergo very frequent checkups as advised by the gynecologist? And those things should be told to these patients. Then the fifth point is, if possible, valproate can be avoided in women, but that doesn't mean that valproate should be avoided. These problems of valproate are generally seen dose dependent, that is, especially if you go above 1000 milligram. And if the patient is on valproate, and because there are many situations where valproate is unavoidable in women with epilepsy. I have plenty of patients with 400 milligram, 600 milligram of valproate who are given birth to 2 children, 3 children without any problems. Of course, the cognitive aspects we are not checked in details, but they don't have very overt cognitive abnormalities. There are many women with valproate, they cannot be seizure free without valproate. In those situations, just tell them, because many of the practitioners are really scaring the women when they see that they are on valproate. So if the patient is on valproate for valid reason, I think they can be continued, because there are women, the moment you drop valproate, they throw seizure and nothing else controls seizures other than valproate. So keep valproate to the minimum dose in these patients, and they can be positively counseled. Then use monotherapy at the lowest effective dose whenever possible. That is the other point which we want to mention. Then folic acid 5 milligram before conception, 3 months before. That means I would say 3 months before marriage. Then monitoring drug levels, if possible. It is specifically applicable to lamotrigine and levetiracetam. But if you are not able to do, you can either increase the dosages from the 6th month onwards, or give increased dose when they throw a fit, and then bring it back to the pre-conception level within a month after the delivery. Most important golden point is seizure control remains the priority. Not when the panic about valproate comes second only. Seizure control is the most important thing, especially if there is a GTCS. It will have very significant risk to both the mother and the child. But the bottom line is that all said and done, 90%, you saw all the numbers, 2%, 3%, 5%, 9%, and the valproate went to 9.5% or something. But 90% are going to have healthy pregnancies. That means if you see 5,000 patients, minimum of 4,500 deliveries are going to be normal, and the other 450 is going to have some minor abnormalities. Because of this particular 90% safety, I would say not having seizure in the mother is the first and foremost. That's something which I want to stress in this meeting, and not the point about valproate. That comes second. First is not having GTCS in the mother. Third, and the 11th point is breastfeeding. Go ahead. There is no question of discussing anything about breastfeeding. It has to be done, and it is vital for the overall well-being of the patient. And thank you all for the patient listening. I know there are many questions which are unanswered, but I tried my best to cover the most important things in the limited period of time. Thank you. Back to Rajesh Babu, sir.
Sir, it was a very nice discussions all over, sir. It was an exhaustive discussion. Almost you have done for almost nearly 1 hour, sir. It was
Yes, sir.
a very overwhelming talk, sir. It was
Thank you, sir.
cleared all the doubts, I think, for the pregnancy. This each and every one gynecologist should have attended this meeting, sir. It's a very, very interesting topic. We will have one more session, a live session. We will have in one of the IMA meetings also the same topic, I think, sir. It will be
Okay,
very
sir.
useful, sir. But only thing is, people are not coming in large numbers for the meetings. That is the main thing, sir. If not, we will go to the next speaker. Okay, now we will have the talk by the next speaker. Then we will, at the end, we will tell all the answers and winners also. So now we will go for the Naveen, you put Dr. Bhagat Singh's. Completed his neurosurgery residency in Madurai Medical College in 2008. He completed MS in Madurai Medical College 2004 and completed MBBS in Madurai Medical College in 1999. He is the first to organize the neuroendoscopy conference in Madurai South, Tamil Nadu, Indo-Neurocon 2013. 2019 organized the sixth annual conference of Neuroendoscopic Society, joined various national and international surgery conferences as invited guest speaker, various publications in neurosurgery journals. He was a clinical fellow at Central of Excellence UPMC Pittsburgh for a neuroendoscopy. Current position senior consultant neurosurgeon at VMCH and RC Madurai. I welcome Dr. Bhagat Singh sir to give his lecture.
Good evening to all. First of all, I thank Rajesh Babu sir and Vikram for this wonderful opportunity as well as for IMA College of General Practitioners to join with us. So there was an excellent talk by Rajesh sir regarding pregnancy as well as women in epilepsy. It's a very fascinating and cover very nicely. Just for the I have some view. I don't know about Rajesh sir is speaking about this topic along with me. So even though I'm much interested in endoscopy and skull base, I have a couple of things work on women and neurosurgery. This is one of the publication I presented in a WFNS conference in Chennai. This is just for as Rajesh sir is here. I just mention it. This is our case series of neurosurgery in pregnancy and all kind of cases. We have a spinal and vascular malformation, infection, and with intrinsic tumor that all complicating pregnancy, and we are operated as a team work with the help of neurologists, gynecologists, anesthetists, as well as neonatologists. And this was presented in WFNS Chennai. During that time, the chairperson was that retired professor from CMC. He asked one question that I shared, which is the most difficult in pregnancy and neurosurgery. I mentioned it is a vascular mass formation with bleed. We have a lot of cases for the past 15 years. I came across a lot of cases in both hospital. Previously, I worked in Minachi. Now I'm in Velamal. More than 30 cases we undergone during the pregnancy. So first early trimester and the early second, the first trimester and the early second trimester, try to terminate and do the proper treatment after the termination of pregnancy. In the third trimester, we have some issues. So this is one of the case very difficult to do in Velamal when I was joined 3 years back. And patient was operated for ICH due to vascular malformation and decompressive craniectomy, and in the second trimester terminated, and then for cranioplasty everything went on well and he was walked home. So these are couple of experiences I just shared because of Rajesh sir is here. So he is a very vast experience and very nicely described woman in epilepsy. We don't have such knowledge. We have most of the patients with the tumor, bleed, unconsciousness, or paraplegic. or some morbid conditions. So we are more concentrating on operation during the epilepsy, during the pregnancy with various comorbidities. But that kind of physiological basis of woman with epilepsy and drugs interaction and pregnancy related breastfeeding and was very nicely described. Just because of him availability, I share this slide. And now I come to my topic today, that is endoscopic skull base, and I confined here to pituitary apoplexy, that also more related to more common in women, as well as it is a common presentation in pregnancy. So I will confine it, cover all the topics because of which all the skull base structures are around the pituitary. Pituitary is the epicenter. So whatever the all other pathologies like craniopharyngiomas and other Rathis cleft cyst, everything is situated around it. So I will cover pituitary apoplexy today. As Rajesh Shankar Iyer sir is here, we can get some additional input, and I also know about more about something from him. So go to the skull base surgery, and it is a very fascinating. We start the walk from the nose and entered into the skull base and reach the inside the brain cavity. So many pathologies are there. And today, the pituitary apoplexy, I took it because of that previous topic is more related to the woman and neurological disease. Come to the pituitary apoplexy, meaning sudden attack, to be struck down. So potentially life-threatening disorder due to the acute ischemic infarction or hemorrhage in the pituitary gland. So normal pituitary gland enlarged during the pregnancy. So it is always not pathological due to various hormonal effect, as Sir described very nicely. So during the pregnancy, there will be a increase in the size of the normal pituitary gland, and there is likelihood of minor bleed is also there. So most of them are taken care by the neurologist and endocrinologist conservatively, and the complications are avoided with the help of neurosurgeon. So the first case reported of fatal hemorrhage in pituitary adenoma by Dr. Bailey in 1898. Sigon in 1938 pioneered the description prototype in obstetric cases. He described it in obstetric cases only. And Broham, who first coined the term and reviewed the reported cases and described till date as apoplexy. So up to 65 to 90% of all apoplexies occur in the patients with pituitary macroadenoma. Macroadenoma is more than 10 millimeter in size. The other associated risk factors are anticoagulation, MEN1 syndrome, dynamic pituitary function test itself cause radiation, bromocriptine therapy, trauma, and other risk factors also there. These are the predominant one. Fifth or sixth decade with slight male predominance ranging from 2.25 to 1. Come to the anatomy, the hypophyseal portal system. That artery is mainly supplied by the superior hypophyseal artery and inferior hypophyseal artery, and the venous system is that hypophyseal portal veins that are drain the both anterior as well as the posterior pituitary. So the anatomy is very clear. There are two types of arterial supply and venous drain through the various venous plexus. So it is a concomitant, and it is very rich in vascular anatomy, and that is the potential cause and that lead to apoplexy if there is any microadenoma. So this is again shows very nicely what are all the things secreted in the pituitary gland and how it go through it and how the venous channel drain it and function into the normal body through the venous channel. It come out, and hypothalamic stimulation, anterior and pituitary and posterior pituitary secrete the hormones and reach the particular site and act on it to survive. Any survival? No. Without the hormones, these hormones we can't survive. So anterior is supplied by the superior hypophyseal artery, which is a branch of internal carotid and transverse along the pituitary stalk. Posterior pituitary is supplied by the inferior hypophyseal artery, which is also arise from the internal carotid, travel in the inferior to the gland. The venous drainage take place within the adjacent venous sinus to the jugular venous system. So pathophysiology, an acute expansion of the pituitary adenoma or rest commonly in non-adenomatous gland from the infarction or hemorrhage. Some postulate the gradual enlarging tumor compresses and distorting the hypophyseal stalk and its vascular supply, that causing the ischemia and subsequent necrosis. Then another theory is they tell rapid expansion of the tumor outstrips its vascular supply, resulting in the ischemia and necrosis. So various postulated theories are there for the pathogenesis of apoplexy. Headache 100% and nausea 80%, reduction in the visual field up to 70%, ocular paresis in 69%, third nerve palsy in 67%, reduction of the visual acuity in above 60, vomiting in 57%, and photophobia and decreased level of consciousness in 11 patients. Most of the patients we have a loss of consciousness. Maybe neurologists and an endocrinologist have the conscious patient with all other symptoms. So SAH differential diagnosis are SAH from aneurysmal rupture, spontaneous hemorrhage from hypertension, amyloid angiopathy, migraine, temporal arteritis, and meningitis, diabetic ocular palsy, and optic neuritis, and cavernous sinus thrombosis. This should be come into the mind when we deal about that patient with apoplexy. These are all the differential diagnosis. The scoring system for apoplexy: level of consciousness, visual acuity, visual field defect, and ocular paresis. Based on this, we can have a scoring system. The scoring system above 6 can be ideal candidate for surgical decompression, and less than 6, we can go for a conservative thing. The important biochemical tests are gonadotroph bio investigations. Gonadotrophin deficiency in 79% of hypocorticolism in 76, testosterone deficiency in 73, and TSH deficiency in 50%, hyponatremia in 40%. So the highest percentage in 79% of patients with gonadotrophin deficiency. So if you suspect if it is a apoplexy, then you can give hydrocortisone at the moment you have a differential diagnosis, and then TSH, that is a thyroid hormones, and the emergency period itself, that should be followed before the proper investigation of MRI. So investigation, X-ray, CT scan to demonstrate the pituitary mass are but not sensitive like MRI. MRI is the radio diagnostic tool of choice. It's confirmed in more than 90% of cases. This is a CT, one of the case with apoplexy with a hyperdensity with macroadenoma, that is more in favor of pituitary apoplexy. So this is a typical picture with mixed intensity, with showing hyperindence as well as hypo as well as hypo as well as mixed intense lesion. So hyperintensity in the pituitary tumor area is more in favor of bleed that cause apoplexy. So this is a algorithm: MRI or CT for a cell diagnosis confirm, deteriorating the level of consciousness, severely reduced visual acuity or visual field. If it is yes, then consider for the surgical management. That are the candidates with this scoring system above 6. If there is no, then conservative management, close monitoring, neurological, visual, and endocrine. The endocrine evaluation in 4 to 6 weeks after that, and visual evaluation. Repeat MRI in 3 to 6 months. Annual biochemical assessment of pituitary function, and annual MRI first 5 years, and then 2 and yearly 2 years. So these are one of the paper in that conclusion is their findings suggest patient presenting with pituitary apoplexy in whom the visual defects are stable or improving may be managed expectantly as there is no identified deleterious effect or visual endocrine outcome. One patient from such group experienced tumor regrowth that is necessitated further treatment intervention, highlighting the importance of long-term follow-up in patients with pituitary apoplexy. Because I show one video that you can understand where is the normal gland and where is the pituitary tumor and where is the bleeding. It is very difficult. Even some of the skull base was totally destroyed and the tumor is coming into the nasal cavity and coming down below the sphenoidal area into the nasal cavity. Outcome and prognosis, lethal outcome, very infrequent. Emergent decompression may recover the pituitary function. The visual outcome, early decompression less than 8 days, improve the visual acuity and visual field, no influence on ocular paresis. And endocrine outcome, long-term replacement is needed in 43 to 58% of cases, transient diabetes insipidus in 16% of patients. So this is our study, and now I have more than 12 patients. To more than 12 patients, it is a previous slide. So these are all patients have a headache, one patient with epistaxis, visual disturbances, cranial nerve palsy, and altered level of consciousness. Most of them, what neurosurgeon received are with the altered level of consciousness. So the stable patients are, most of them are the patients of neurology or endocrinologists. Most of the patients presents with abnormal endocrine functions next to sudden onset of severe headache. So outcome, these are all some of the post-operative pictures. I will show the video now. These are references, video. அதில்லப்பா கடைசி. So this is one of the patient. I entered into the nasal cavity and it was play பண்ணு சார் சார் ஆகுது. So this is one of the patient operated with bleeding, entered into the nasal phase and sphenoid was opened up and the tumor was coming and crossed the sphenoid with bleeding because of the erosion with the long-standing tumor with bleeding cause that a bony erosion and the tumor is descending down into the sphenoid sinus and come into the nasal cavity. So anatomy is always disturbed in the pituitary macroadenoma with bleeding. Usually the sphenoid ostium is located at 1.25 to 1.5 centimeter from the choana, but in this kind of apoplexy with bleeding, we never expect a normal anatomy in the skull base and cellar area. So it is mostly some distorted anatomy in most of the cases. So this is one such case, and we removed the bleeding, and then the remaining tumor we removed. So very difficult, which is the normal pituitary and which is the tumor and where is the bleeding, and there is no direct demarcation between the two. I will show another video. So the most common this is another video. This is a proper step. So we have 3 steps in endoscopic skull base surgery: nasal phase, sphenoidal phase, and skull base. And then another 3 phases or another 2 phases like entering into the tumor phase and cavernous sinus phase and reconstruction phase. Previously we consider as a 3 phase, now 6 phases of and skull base endoscopic surgery into the pituitary area. So all these 6 phases should be taken care very carefully. Reconstruction also very important when the most of the functioning tumor, their involvement of the cavernous sinus is always there. So exploring the cavernous sinus is also important. This is one such case. We remove the entered into the sphenoid space and skull base is drilled out and the dura was exposed and open up the dura and this is opening up the dura. There are various techniques in opening up the dura. Usually I go through the transverse. Now you see the tumor with bleeding. So it is one of the pituitary apoplexy. So I have a couple of studies. I have interoperative MRI for the very large tumor. There are certain videos, but it takes some long time. So very difficult whether the total tumor is removed or there is a remaining tumor is there or not. And when there is a bleeding, it is very difficult intraoperatively to identify the normal structures from the abnormal gland and the tumor. So also I have a application of ICG to find out the normal gland. That also not very helpful, especially in case of apoplexy. It is not at all useful because of the blood pooling. The blood pooling into the operative cavity make it not useful, but it is very useful in a functional adenomas. Before opening up the dura and identification of the functional microadenomas, and the ICG was very useful. They're important tool. The interoperative MRI were the huge tumor with bleeding, and for a microadenoma with the functional lesions, the ICG is useful. These two techniques, I have a couple of studies. My residents did it, and now I am following here in Velamol also. So this is a reconstruction. Now 6 phases in endoscopic skull base pituitary surgery: nasal phase, sphenoidal phase, skull base, and tumor phase, cavernous sinus, and reconstruction. So every step is important. So the most common secreting tumor, hormone secreting tumor, is a prolactinoma. That prolactinoma with apoplexy is very difficult for many of the reasons, for a post-operative follow-up as well as for the hormone replacement. So usually functioning tumor with bleeding is less common than a non-functioning adenoma with bleeding. Most of them are 90% is a non-functioning tumor with bleeding that cause apoplexy. So this is a reconstruction phase. That reconstruction of skull base using the Haddad flap, nasoseptal flap, and then after that, nowadays we are not using this FOLIC catheter because of the flap necrosis. So these are all the steps for the endoscopic skull base pituitary surgery in the pituitary area. So with this, I stop my talk and give us some brief idea. I plan to go over general endoscopic skull face with all pathology. After a talk of Rajesh sir, I confine myself to pituitary apoplexy. It is more related to the hormones and pregnancy related thing, and I confine the skull base with the apoplexy related thing, and I think cover all the anatomy. And any question, I am ready to answer. Thank you once again for the Rajesh Babu sir and Vikram. And any questions should be, I am ready to take it.
Thank you, Dr. Bagathsingh sir. It's a great honor for us to have Dr. Bagathsingh and Dr. Rajesh Shankar Iyer in this tight, busy schedule to be with us for these 2 hours in this Neurosciences Forum to educate the participants of the Neurosciences Forum webinar. Thanks for sharing your expertise in a crisp and useful manner for all the participants. We have a lot of GPs and postgraduates. Definitely, each point what Dr. Rajesh Shankar Iyer sir has shared about epilepsy in the woman and basic concepts and applications of apoplexy and skull-based surgery by Dr. Bagathsingh would have helped most of them to understand what is happening in the neurosurgical skull base and treatment management for epilepsy for women
in a great manner for their day-to-day practice. Hope this converts into their day-to-day life in somewhere or other in their practice. Thanks a lot, sir. Thanks for saving your time for this webinar. Thanks a lot, sir. Thanks, Rajesh sir, and thanks, Bhagat sir.
Thank you.
Rajesh sir, and
Thank you for all the
for
participants.
helping us.
Thank you,
all the
sir. I
participants.
also learned a lot of things. Thank you so much for the opportunity.
Thank you. Thank you all. Thank you for the opportunity.